Disc injuries are super common. Almost everybody at some point in their life will injure or have some sort of problem with the intervertebral disc of the spine. So let's talk a little bit about disc injuries and how we diagnose them and how they should be managed. The disc really has two components: the inner nucleus, which is a cushion, and the outer annulus, which is the structural component to keep the nucleus where it should be and to provide stability to the segment. Discs do a lot of things for us. They help provide stability, motion, they cushion our backs, etc., etc. Most of the disc injuries involve the annulus, and they're very painful. Sometimes patients come into the clinic and they've injured their disc. They have an annular tear, for example, and they're in a ton of pain. And we look and say, well, you don't need surgery for it. And they walk away thinking that we don't care about them. Well, we do care about them, but most disc injuries don't require surgery. Also, most disc injuries improve with time and conservative treatment. So let's talk briefly about the diagnostic evaluation and then the management. So if a patient has red flag symptoms, we like to get MRI scans pretty early. X-rays, especially flexion extension and dynamic x-rays with the patient standing, give us a lot of information for not a lot of cost. We want to do a physical exam. We want to know the nature of the symptoms. Are they just localized to the low back? Are they radiating down the leg? Is there associated weakness, numbness, bladder problems, etc.? As far as management goes, if a patient has a severe disc injury, they have weakness, bladder problems, we may go straight to surgery for something like that. But in the vast majority, we're looking at a course of conservative treatment. We want to keep the patients moving. We want to refocus on nutrition. I think physical therapy and chiropractic care are really helpful. And then in some situations, an injection to help with the inflammatory response, and some medication, including an oral course of steroids, maybe a muscle relaxant, because when the disc is injured, the muscles really spasm, and that can create a secondary pain. If the patients are not getting better with conservative treatment, and there's no red flag symptoms, then we start to think about doing surgery a little bit later on, 2 or 3 or 4 months in, depending on the nature of the problem. The times when surgeries are the most helpful are herniations that go into the nerve and affect the nerve with radiating leg pain. And for that, we do a discectomy and remove the fragment. We're not removing the whole disc, we're just removing the fragment. So remember, we're not fixing the disc when we do a discectomy. We're alleviating the pain going down the leg. We also have disc replacement and fusion. I love disc replacement for patients that have disc injuries that are not getting better, because it's a definitive treatment, and it tends to have very good outcome. Disc replacement isn't an option for everything, but when it is an option, we like to do the disc replacement. And if we really have to stabilize a disc, it's a bad level, it's herniated once or twice, it has a lot of associated arthritis, there's a slip in the disc, etc., etc. For those kinds of patients, we'll think about doing a fusion. So if you've had a disc injury, rest assured, because I know there's a lot of anxiety and fear associated with an injury to your back, and lots of horror stories out there of people that have lost their function and lost their jobs and had a miserable course with back injuries. There's a lot of people here to help. We want to be managing this in a way that keeps you out of harm's way and gets you back to life and back to work as effectively and efficiently as possible. And when we do our evaluations, there's a lot of nuance. There's a lot of reasons why we would do surgery and why we wouldn't. Generally speaking, and most of the time, we can have the physical therapists, chiropractors, and some pain management get involved and really help you through the first week to month or two. And for the most part, patients get better in a short time frame. If not, then we start getting a little bit more serious about surgical interventions and longer term management strategies.